Good evening and welcome to our webinar on explosive outbursts and Tourette. My name is Ali Gemma, CDC Program Director, and I will be your moderator for the webinar. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During the webinar, we will be very happy to hear from you and include your voice in the conversation. You can ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. Additionally, you'll note that we have a handout of the slides that you can download from your control panel and will be discussed in the presentation. I want to mention that that funding for this webinar was made possible by the cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. It is my absolute pleasure to introduce you to our speaker this evening, Dr. Kathy Budman. Dr. Budman is the Director of the National Tourette Center of Excellence at Northwell Health Psychiatry and Professor of Psychiatry at Hofstra University School of Medicine. Dr. Budman has been treating families with Tourette and associated disorders since 1988 and is involved in research investigating explosive outbursts in Tourette, clinical trials for treatment of tics and associated psychiatric disorders, neuroimaging studies in Tourette, and genetics. Dr. Budman has served on the Tourette Association's Medical Advisory Board and is a member of the Tourette Association Clinical Trials Consortium and the International Consortium for Genetics. So I'm going to hand it over to Dr. Budman in just a moment, but I just wanted to get an idea of who we have participating on the webinar. So I'm just going to go ahead and launch our polling question. And the question is going to be, what is your relationship to Tourette? If you can go ahead and just take a few seconds and submit your answers. And it looks like at the moment we have about 72% parents, 13% professionals, some individuals with Tourette. All right, so just give it a couple more seconds. All right, it's pretty much about the same. So 70% parents, 40% professional, 6% self. All right, great. So thank you for your answers. Dr. Budman, this should give you a feel for who we have participating live on the webinar. Again, we encourage you to submit questions and comments anytime in the question panel, and we will do our best to answer all of them at the end. If we do not get to your question, please feel free to email the Tourette Information and Referral staff using the email support@tourette.org. So now, Dr. Budman, please go ahead with your presentation.
Thank you very much. It's a pleasure to address this audience. I'm sure most of you who have tuned in tonight are aware that explosive outbursts are among the most challenging and really troublesome symptoms that can be encountered in people with Tourette syndrome. So this evening, I'll try to give you an overview of this particular symptom, and we'll touch upon possible etiologies, possible treatments, and possible causes. I would like to share with you my disclosures. I received grant support from Otsuka Pharmaceuticals, Synchroneuron, Cyodon, Auspex, Teva, and Neurocrine Biosciences. I'm also a consultant for Bracket. And as mentioned, I served on the National Medical Advisory Board and continue to serve on the Long Island Tourette Association Medical Advisory Board in the Long Island, Chad. And I am a speaker for the Tourette Association of America's CDC partnership. When we discuss medications tonight, it will be primarily off-label, which means these are not FDA-approved indications for the most part. Okay. So, in order to understand explosive outbursts and Tourette syndrome, I think it's helpful for us to have some sort of background vocabulary, and these are relevant concepts. So first, let's review the definition of impulsivity. And I think most of us know what this is when we see it, But let's just emphasize, these are very usually abrupt, unplanned reactions that occur without really thinking about the consequences. All right? The jump before you see where you're jumping, react before you think about the consequences or effects on the other person. That's a definition of impulsivity. Compulsivity, right, in contrast, is performing repetitive actions or behaviors that are actually used to reduce an anxiety or unpleasant feeling, and that could be an external feeling or an internal feeling. It could be an emotional state or buildup of tension. Now, what's frustration? Well, of course, all of us have experienced frustration. It's a normal part of life, and it typically occurs when one's efforts or progress towards a particular objective or goal have been thwarted. So, what would one normally do in that case? Well, you might try to either direct your efforts towards a different goal if your current one is untenable, or you might actually say, all right, that strategy didn't work. Let me try a different strategy to achieve that goal. But what happens if you can't, you sort of keep banging your head against the wall, keep performing the same activities or actions that were previously rewarded, previously ended in success, but now they're not, all right? Or what happens if you actually are unable to generate an alternative strategy or goal? Well, in those cases, and this is very common, I'm sure most of you who suffer from Tourette and its associated disorders, or if your children do, you realize that these are the instances when the risk for frustration is really very much increased. Now I'm going to review with you very, very briefly that when we talk about impulsivity and we talk about compulsivity, often it seems as if these are black and white categories, but the truth is there's a continuity between these different types of behaviors and symptoms. And there are some that really have characteristics of both impulsive disorders and compulsive disorders, and we call these the impulsive-compulsive spectrum disorders, and this is a list here for you. But the one that we're focusing on tonight is intermittent explosive disorder. Now, why would we do that? Well, it turns out that it's actually among the most common impulse control disorders that are seen in Tourette samples in clinical populations. So you can see almost small sample size here, but this was performed on an adult sample in a specialty clinic with Tourette syndrome patients, and over half of them suffered, actually met diagnostic criteria for intermittent explosive disorder. So it's probably the most common impulsive-compulsive disorder in Tourette. Now let's focus with a little background on aggressive symptoms in general, and more specifically aggressive symptoms in Tourette's disorder. So most of you are familiar with aggressive behaviors that occur in animals, and I always like to remind people that we are animals too, and so we're subject to similar behaviors. So you can see dominance behaviors, right? The alpha male, for example, right, exerting dominance. It might happen in an office situation and may happen between two dogs of the same breed, for example. Territorial aggression is generally an attempt to establish dominance in a sense over a particular resources, often food or just general property, etc. All right, again, think of an example in humans where your neighbor puts up a fence to sort of, designate territory between their property and your own. And then there's female aggression, and this isn't, just PMS. This is the type of aggression that occurs primarily when a mother is threatened in terms of her children, all right? So in the animal kingdom, typically this will generate an aggressive response. excuse me. So we know that aggression can be a normal symptom. In fact, it is a normal symptom in our repertoire of behaviors. And a certain type of aggressive symptoms called developmental aggression or temper tantrums, again, considered quite normal part of development in children. Now, temper tantrums, which many of you are probably familiar with, they're really most common in young children. So the overwhelming majority of temper tantrums occur in children under age 5. Much less common as children reach puberty and their repertoire of self-regulatory behaviors has increased, and their ability to inhibit urges has increased. Temper tantrums are actually more common in boys than girls, and they also seem to be more common in children who have bedwetting, sleep problems, hyperactivity, head banging, and tics as well. Temper tantrums typically are brief. They may occur a few times throughout the day, but they're typically short-lived. And again, most of you are familiar with these examples of sort of breath holding or kicking and hitting, pinching, crying. Well, we said that developmental aggression is a normal part of human behavior, but what is pathological aggression? Well, by definition, pathological aggression is aggression that is excessive. It's excessive in its intensity, it's excessive in its frequency, it's excessive in its duration. And importantly, it's inappropriate. So it's excessive and it's inappropriate. It's inappropriate for age, it's inappropriate for social context, it's inappropriate for the frustration or demand. And this type of aggression can be directed towards self, it can be directed towards family members or strangers or friends. So many of you have heard me speak before, familiar with this slide. This is probably the world's most famous psychiatrist, Hannibal Lecter. But he's a superb example of what we would call proactive pathological aggression. Proactive pathological aggression is a different type of aggression than what we typically see in Tourette syndrome. In this proactive, or what we call non-impulsive or predatory type of aggression, usually has an age of onset around 6.5 years. It's associated with aggression in family members. Usually there's domestic violence, history of domestic violence or physical abuse in the family. And interestingly, this type of non-impulsive predatory type aggression is associated with a decrease in heart rate, in blood pressure. Actually, while performing the aggressive act, this individual feels calmer. They actually have physiological parameters that indicate that they're calmer. And this is typically seen in different types of psychopathy or sociopathy, delinquent behaviors, and bullying. Now I'm going to emphasize this particular aspect of predatory aggression, which is called relational aggression, because this is something that can be encountered certainly in our TS community. And this type of aggression, interestingly, we found was associated with an increased frequency of explosive outbursts in the children with Tourette. So children, we did this study called the Tourette Syndrome Impact Study a couple of years ago, and found that when we looked at children who had reported, children with TS who had reported being bullied or peer victimization, that actually not only did they have greater tic severity and complexity, but they were more likely to have rage attacks. So being the victim of predatory aggression actually is a risk factor for rage. Now let's talk about the relational aggression again. What exactly is happening? Well, it's typically a deliberate manipulation, a deliberate attempt to damage relationships or social status. So it can be a situation where there's a power play for popularity or to coerce another. Usually has an onset in preschool, and And when it says parent-child relations are a strong influence, well, it's often endorsed by parents as well. And examples that are common to many of you are cyberbullying, but more commonly, the type of exclusion that might occur. You're not invited, your child's not invited to a birthday party, or they're ignored. So despite advocacy and some of the best efforts at public health education, some of this type of aggression in the non-TS community is still really a great challenge for us. Now, the Incredible Hulk, I like this example because he's more typical of what we see in Tourette syndrome. All right, this is a reactive or impulsive type of pathological aggression. Typical age of onset is about 4.5 years. It's often associated with, in contrast to predatory aggression, an increase in physiological parameters. So, the fight or flight phenomena, the blood pressure goes up, the pulse goes up, just ready to run and attack. And in various other disorders, it's been described as affective storms or rage attacks. Now, we know that there are a number of different neurotransmitters that have been implicated in aggression. Certainly serotonin plays an important role, but also norepinephrine and dopamine. And I'm going to just sort of leave this slide for you to have a look at for a second, because you'll realize that some of these very common comorbid or co-occurring conditions in Tourette syndrome, these neurotransmitters, dopamine, norepinephrine, serotonin, are implicated in these co-occurring disorders. So they play a role in regulating mood, inhibition, and also aggression. Now, what's interesting is some recent studies have shown that, at least in adults, the adults seem to react more robustly to what they consider or perceive as an angry or fearful expression. And so the adults also seem to have, this is based on a study that Kavana did in 2013, that they actually have perhaps a distortion or very subtle alterations in the way they process social information. So, for example, they might perceive something as threatening when it's not, or something as critical when, in fact, it's not critical. So I leave you a quote here because I think this is relevant to our TS community. So, fear is the path to the dark side. Fear leads to anger, and anger leads to hate, and hate leads to suffering. Well, fear certainly can lead to irritability, and it can then proceed to anger and explosive rage. So what are some general causes of aggressive symptoms? And now we're talking about, not just for the TS community, but in general. Well, this is a list here, and you can see medication side effects is an important one. Medication interactions and side effects is an important one. Physical abuse, we mentioned bullying. Pain, very important. Sleep disorders, and other types of pre-existing or co-occurring psychiatric conditions. These are some of the medications that have been associated with aggressive symptoms, and as you can see, I starred a few, actually didn't star the typical and atypical, but the stimulants, the alpha agonists, the antipsychotics, and the serotonin reuptake inhibitors and other antidepressants. These are all very commonly used for treatments of either tics or co-occurring conditions. So always important to assess whether or not that may be a cause of aggressive symptoms. Certainly, if you can see a cause and effect between new onset of these symptoms and starting a medication, then that really raises your index of suspicion. And these medications have been associated with a number of what I consider different types of behavioral toxicity. So some of the medications that we use to treat tics and its co-occurring conditions can lead to activation. They can exacerbate disinhibition. You can get a paradoxical excitement. So, For example, a medication that's supposed to be sedating may instead be activating. And you can see a variety of things like increased anxiety responses, etc. Now, let's look more specifically at causes of aggressive symptoms in various psychiatric conditions. And you can see here that obsessive compulsive disorder, non-OCD anxiety disorders, mood disorders such as major depression or bipolar, autistic spectrum disorders, and oppositional defiant disorders are very common causes, common disorders that are associated with rage or aggressive symptoms. Well, this is interesting because when we talk about Tourette, you can see, based on our most recent literature, that the overwhelming majority of individuals who suffer from Tourette syndrome have had, at least at some point in their life, a psychiatric comorbidity. In fact, over half have had more than 2. So, again, the risk here is significant. Now, I'll just give you this. You can see it in your handout, but this is sort of the DSM-5 Diagnostic Criteria for Oppositional Defiant Disorder, and you can see it overlaps quite a bit with what we would often call rage. So often loses temper, angry, resentful, defiant, deliberately annoying others, etc. You have to consider whether this behavior is age inappropriate, whether it's inappropriate for gender and culture, and by definition, it really has to impact on functioning, so it can't be just sort of isolated episodes. And it's actually fairly common when you look at it, and very common to have multiple comorbidities. Another diagnostic entity that we consider when we're faced with an individual, a child or adult who is presenting with aggressive symptoms is this new diagnostic entity. It's called Disruptive Mood Dysregulation Disorder, and I can give you a little bit of background here. This was an attempt to circumvent the excessive diagnoses of bipolar affective disorder in children. And it was felt that many of these children who were receiving diagnoses of bipolar, in fact, didn't follow a typical trajectory for bipolar if you followed them prospectively or you followed them long-term. So this new diagnostic disorder, the disruptive mood dysregulation, was designed to capture these children who have considerable irritability and explosive behaviors, but they are not bipolar. All right. And you can see here that you can't make this diagnosis in the presence of intermittent explosive disorder diagnosis or oppositional defiant diagnosis or bipolar. And these behaviors can't be occurring exclusively during an episode of depression, but it can, you can make the diagnosis when either ADHD or substance abuse or major depression are present. So it's not exclusively during an episode of depression, but a history of depression doesn't prevent you from making this diagnosis. And here are the diagnostic criteria for intermittent explosive disorder, and these are episodes of recurrent explosive anger. It could be verbal aggression, it could be physical aggression, it could be both. They have now required at least 3 outbursts in the past 12 months that result in serious damage or physical assault to others. So these are behaviors that are very grossly out of proportion to their provocation or stress. They are a reactive, all right, impulsive type of aggression. They're not premeditated. They're not, you know, that sort of psychopathic aggression, and they're very, very impairing, not only for those around them, but for the person who suffers from them. And this is just a little more sort of diagnostic criteria for you. So let's now bring the discussion down to Tourette. What do we know about aggressive symptoms in Tourette syndrome? Well, we know they are very common. In fact, they're one of the most common presenting symptoms in most child psychiatry outpatient clinics. We also know that this impulsive, not meditated, reactive type of aggression is the most typical type. The etiology of these symptoms certainly is not always straightforward, and we know, as I said before, that the impact or the morbidity is considerable. It's quite significant, and the treatment can be very challenging. This is just some data from a large international database which showed that, you know, almost 40% of people have suffered with Tourette have suffered from anger control problems at some point. A very, very few, however, who only have tics, and we know that that is a very few, you know, small percentage of the overall population of people with TS. Very few suffer from anger control problems if tics are their only symptom. So using a modification of the diagnostic criteria for intermittent explosive disorder, we defined explosive outbursts as these abrupt, unpredictable episodes of very severe aggression, grossly out of proportion to any provocation or frustration. Their experience is uncontrollable, and they're accompanied by physiological activation. So these are your reactive, impulsive types of aggressions. And this was a study we did a number of years ago, but we found that there were really sort of 4 different clusters, and they sort of grossly corresponded to different entities. So this labile non-resolving, for example, that may actually be more like what today would meet diagnostic criteria for that dysphoric mood regulation disorder. The other ones, environmental, tended to occur primarily in a context at home when there was increased expressed emotion among parents and child. And then there is the specific urge, which was really more a compulsive type of aggression, and non-specific, which was more sort of impulsive ADHD-like subgroup. This was a study that we looked at explosive outbursts actually in 2 different populations in the U.S. and Costa Rica, and we found, apart from seeing that there was at least 20% of the population in both samples, so it doesn't occur only in the United States. In the Costa Rican population, it was associated with tic severity, but and an earlier age of onset of tics. In the American one, it was associated with tic severity, ADHD, and nicotine exposure. And just again to emphasize this point that these behaviors occur worldwide, they're not described only in the United States. This was a fairly recent study that was done by Kano in Japan, and they showed tic severity and self-injurious behaviors being associated with rage, and that actually the frequency of the episodes is probably the best way to sort of distinguish significant rage symptoms from non-significant. So if you have a rage once a year, we're not going to call that explosive behavior, but if you're having rages, you know, a few times a week, that's really clinically significant. So at this point, we think that the explosive outbursts in children are certainly associated with specific psychiatric disorders. They may be generated by certain psychotropic medication side effects or interactions. And we also know that there are significant environmental factors that play a role. And I'll touch on these very briefly. I mentioned high expressed to family emotion. So if there's a lot of sort of yelling and crying and screaming and, you know, high sort of temperature of emotion at home, that certainly increases risks for explosive outbursts, but also something called family accommodation. And I'll try to explain that a little later if we have some time. So how do we assess these symptoms? Well, we look at the frequency, severity, duration, triggers, and context. And it's important really to review this with either your doctor or your child's doctor to get a handle on what might be underlying the symptom. It's really, really important to have what I would consider a comprehensive psychiatric and medical evaluation, and a neuropsychological evaluation in certain circumstances, as well as a really good overall assessment of psychosocial environment. Why is that? Because, as I said, you know, there may be subtle, very subtle and undisclosed factors that are contributing to rage. I always ask about bullying, and I just want to sort of emphasize that. I always ask about bullying because many times a child will not disclose their bullying, and they really, you know, they're fearful it will be made worse, and they don't want to tell their parents about it, and yet when it comes up in the office, it's a significant finding for me. You want to always look at the possibility of a medication side effect or drug interaction, and you want to see what's happening at school, within the family, and with peers. Now, actually our first line of treatment is not medication, so I'm going to spend very little time on this, only to give you an overview that when our more conservative non-pharmacological strategies are not adequate, then we may need to think about medication. However, if we can identify a specific co-occurring condition, so for example, let's say your child with Tourette's disorder also has obsessive compulsive disorder, and this obsessive compulsive disorder is actually untreated major source of you know, distress for your child, and may in fact be the reason that you're seeing these explosive or rage symptoms. Well, then that needs to be treated, but the medication may or may not be your first choice for that either. So you're going to use medication when there's a specific co-occurring condition that you can identify and that requires medication treatment, or in situations where more conservative strategies have failed. So what are these more conservative strategies? Well, there's a number of them, and often we may recommend some combination of these different treatments. So, for example, as my colleague John Walkup has often said, you know, parenting a child with Tourette's disorder often requires industrial strength parenting skills, and I agree with that. It's very difficult, particularly when it's complicated by these co-occurring psychiatric disorders like ADHD and OCD and depression, learning disabilities, etc. So parent management training or parenting skills training can be very, very life-saving. Multi-systemic therapy is really where, again, the approach is taken to look at the family as a whole and what other factors may be contributing to the explosive behaviors in one family member. Now, I mentioned briefly some studies that indicated that some adults with Tourette syndrome may have difficulties interpreting social skills, and we know that also occurs in children. So social skills training is an important strategy that can be used. Problem-solving skills training, or PSST, another type of problem-solving skills training is collaborative problem skills training. Well, often, and this was sort of a revelation for me early in the career, when I realized that many of the children I was working with, it's not that they wanted to be rageful or explosive. I mean, it was really much more painful for them than it was even for those around them. But they didn't know, really, they didn't have the skills to manage their emotions or a interpersonal situation better. And so working intensively on developing a repertoire of problem-solving skills is really critical. And there's dialectical behavioral treatments and anti-bullying and you know, of course, some very practical things like improving sleep hygiene, because I'm sure all of you know how cranky we all get if we don't get enough sleep, and so many people with Tourette and co-occurring conditions really have problems with sleep and problems with getting enough physical exercise, etc. Again, these are just a few more of these non-medication treatments that can be very, very helpful. So, for example, relaxation therapy, which is a component of most of the other treatments I just mentioned. But learning how to relax is really important, and it's a skill, that can be acquired. It's not always intuitive for most of us. Organizational skills training, again, very important, because many of the children and adults with Tourette have difficulties in executive functioning, in organizing themselves. They're easily overwhelmed. Providing them with skill sets in this area is really important as well. Respite care, hard to get, actually, at least in our community, but you know, this is a long haul, and parenting is not something you can take a break from, and yet I think in many cases you know, there's real burnout, and so being able to get some sort of respite care, whether it's just, you know, an overnight babysitting or, you know, a weekend, that's important to consider. And unfortunately, the resources in most communities are lacking for this. And then changing things in the environment that require modification. So it might be a workplace modification, it might be classroom or school modifications, and again, emphasizing here the appropriate and timely recognition and treatment of co-occurring conditions, not only in the child or adult with the anger attacks, but in other family members as well. That is really important. So, again, this is my Star Wars talk today, and I think Yoda is a pretty wise little fellow, and he says, you must unlearn what you have learned, and there's some truth in this, because when you're managing these symptoms, you really have to sort of kind of alter the way you think about the behaviors. The way you treat these behaviors will have a big influence on how you manage them. And so if you think your child is just a bad person, you might respond in one capacity, and if you think, well, gee, my child really doesn't know how to manage this situation differently, then you might behave differently. So this here is, I'm just going to give you a flavor. So let's first focus on a parenting management skill. So PMT, parent management training, basically the goal here is to improve maladaptive patterns of family interactions that might be associated with these rage attacks or explosive behaviors. And it relies essentially on a behavioral assumption that depending on whether a behavior is reinforced or not reinforced, it will be more or less likely to recur. So let's have an example. All right, if you have a child, Johnny, and Johnny basically trains you to allow him to watch his favorite show because he rages, and you think, poor Johnny, he has Tourette syndrome and his life is really so challenging, and he's frustrated, so sure, I'm going to let him do this. Well, in a sense, as a parent, you're inadvertently reinforcing that behavior, and Johnny is training you and you are training Johnny to continue raging in order for him to get that desired goal, right? But you can also have a negative reinforcement like spanking, for example, so that a child who is spanked every time he has an explosive outburst might similarly be trained to continue doing that. It's a negative reinforcement, but potentially a reinforcement nonetheless. So what one would do working with the family is to really sort of dissect these behaviors and try to see, you know, exactly what is going on and what is inadvertently being reinforced and what is not actually being positively reinforced in the way it needs to be. And so the goal is to improve parenting skills for dealing with the maladaptive behaviors. And in turn, that has an effect on reducing aggression. Another one, again, I'm just giving you a very quick overview of these different types of behavioral strategies that are used, but another one would be a cognitive behavioral approach that is aimed at the child. And there's a lot of work that's been done by Dennis Sudakovsky and Larry Scahill at Yale. They have a nice manual about CBT therapy for anger and aggression in children you might want to look at. But basically, it sort of starts on the principles that, that the child's problem-solving skills need to be bolstered. And so the emphasis is on learning how to recognize, for example, symptoms of anger, how to sort of short-circuit them before they become explosive, and to have a toolbox of strategies to self-regulate and manage. And in turn, even if it's not 100% successful attempt, parents will learn to praise these attempts at self-regulation to sort of increase and positively reinforce them so that the child is more likely to continue to try to work on these strategies. So I'm going to leave some time for discussion here, but I would just like to sort of end with why is it important for us to recognize and treat these symptoms? Well, again, I think how you perceive something will determine how you treat it. And so if you just say that's a terrible person and he's, you know, got just terrible behavior, or she's just, you know, awful and explosive and can't manage her emotions, well, that's sort of a negative way of looking at that individual, and that's sort of going to color how you interact. Also, you know, we emphasize that in many cases, if not most cases, a underlying psychiatric co-occurring condition may be present. And if you just label that person as, you know, a sort of you know, defiant child, you're missing an opportunity to actually get at the root of a problem that could be specifically treated. And that goes along with poor treatment decisions. So if you make the wrong diagnosis, then you may evoke the wrong, you may embark on the wrong type of treatment strategy, which will not only delay appropriate care, but will sort of reinforce inappropriate care and may end up with a much worse situation, as some of you may have experienced. So the overall impairment actually is at stake. It's also important because, as I mentioned at the beginning, these explosive outbursts are symptoms in Tourette's disorder that are a major cause of marital strain, of caregiver strain, of strained peer and sibling relationships. So there are really negative effects on so many areas that are so important for self-esteem, confidence, and you know, ability to function. So I think with this, I'm going to open it up now for Q&A. Thank you.
Thank you, Dr. Budman, for a great presentation. You know, I think this topic is such an important one, and you know, thank you again for that fantastic presentation. So we're now going to begin answering the questions that you submitted during tonight's presentation. And as a reminder, you can still submit your questions through the questions pane in your control panel. So we've had a couple of questions come in so far. So I'll start at the top. So Dr. Budman, what can we do to calm our daughter when she is in the middle of a rage? How do we help to stop it?
Okay, so this is an excellent practical question and comes up all the time. You know, all of these strategies that I tried to emphasize during this talk, well, it's not going to do very much in the heat of an explosive outburst, will it? So the number one thing that I urge the parents to do in that setting is really just completely shut down, be quiet, do not move, you know, eliminate further, you know, conversation, movements, etc. Any kind of, at this point you have a very overstimulated child and you want to reduce stimulation as much as possible. If you can say, you know, quietly, listen, you know, let's go calm down, we'll talk about this more when we all feel calmer, that's great. A scenario I hear about quite a bit is that the child is escalating and the parents then get activated themselves, and it's a screaming match and things really get very out of control. Or that the parent makes an attempt to actually quiet themselves, go to their own room, and the child follows them and continues to rage, or vice versa. The child makes an attempt to self-regulate, and the parent, who is still angry or anxious and trying to calm the child down, pursues them and tries to continue the engagement. So basically, my message is reduce the stimulation. Think about situations, if any of you are familiar, when you have a young infant and you take that infant to, let's say, a family gathering, and there's just too much noise and too much light and too much movement, and the baby's crying. Well, what do? You don't stay there, hopefully, right? You try to move that infant into a quieter environment and reduce the stimulation. It's very much the same. So I hope that answered the question.
Thank you. So we now have another question. My daughter had rage attacks with destruction of property, abusive language. She was also a bully to her younger siblings. How does this factor in?
Okay, so actually, when I hear about, I'm sort of focusing on the third description there, that she is a bully to her sibling, and so that sort of raises a red flag to me whether this is a child who's being bullied herself at school. Because a number of children who bully others are, in fact, bully victims. They're being bullied. So you'd want to look at that. Now, could you repeat, what were the other two issues that she is?
Sure. So she has rage attacks with destruction of property, abusive language, and she's a bully.
So
how does this factor in?
What happens afterwards, I guess, is what I'd like to know. So after there's been destruction of property, and things have calmed down, what happens next? Is this a situation where child is punished and that's the end of that, or is this child given an opportunity to sort of make good on the destruction of property? And I think that that's an important piece here, because in the throes of an acute rage attack, there's not a whole lot of learning that goes on, right? The acquisition of coping skills is really when things calm down. And so depending, let's say if the child broke, I don't know, a piece of furniture or something, I mean, I would try to give them an opportunity to make good in some way, not just punishment, but also to kind of give them an opportunity to perform behavior that might restore their sense of also being a good person. So that would be one thing. Now, I don't know if this particular individual has read Ross Greene's Explosive Child, but that's a pretty good book to read about this kind of scenario too. And so I think what Ross Greene would tell you is, in that case, when safety is involved, or that's key. But sometimes swearing sometimes is something that is amidst the rage, but perhaps not the thing to focus on, right? So I'm not saying it's okay to swear. I'm just saying that I think you have to sort of find the calm moment afterwards to strategize and come up with some better options for behaving together next time.
Thank you, Dr. Bowman. So we have another question. How can I teach my 11-year-old to read his friend's social cues and body language? He has TS plus, I believe, ODD and ADHD, and will talk over people and ignore others' frustrations with him.
So that's a very, excellent question, and a good example of, a very common scenario. So I guess my first question is this child's ADHD being treated? Because if you have a child who has ADHD, and we know that that means their ability to resist impulses, their ability to inhibit impulses, their ability to tolerate frustration. I mean, these are just cardinal symptoms of ADHD. So if the ADHD itself is poorly controlled, I think it's sort of like asking somebody who's nearsighted to read the eye chart correctly. It's not going to happen. So the first thing would be to have the ADHD adequately treated, and that doesn't mean just medication, by the way. That means addressing other aspects of the ADHD, whether it's some classroom modifications that might be necessary, the dealing with sleep issues, which are so common with children with ADHD, and having that child actually, if possible, get some social skills training on how to effectively cope with conflict and other things that arise.
Okay. So we have another question. How do you differentiate IED from mood dysregulation disorder if both are reactive?
Now, that's a very good question. And so if you refer, I think those are both on the handout, the diagnostic criteria, but in the case of mood dysregulation disorder, it's really kind of pervasive mood throughout the day. Most of the children that I see, they're not really just irritable all day long. In fact, they may be in a pretty good mood until, well, let's say in the case of a child with ADHD, they're frustrated by something, or in the case even with OCD, they're frustrated. There's been a change in a routine, or some compulsive behavior has been frustrated. So I think that the cardinal difference between these is an intermittent explosive disorder. You don't have that persistence of the mood dysphoria throughout the day.
Thank you. So we have another question. Would it be common for a 13-year-old to have these explosive outbursts at home with parents, but never at school or other places?
Such a good question. Great questions. Yes, in fact, when we tried to characterize these symptoms using a questionnaire, we found that the overwhelming majority of explosive outbursts occur at home. And for some of you in the audience, this isn't surprising. The number one target is usually the mother, with the father and siblings being less frequent targets. So how do we understand that behavior, and how do we understand it sort of in context of other symptoms of Tourette syndrome? Well, I'd urge you to think about tics in general. All right, most of you are probably familiar with the fact that your child or adult is more likely to tic at home than in a school environment or work or social setting as well. It's easier to inhibit. That's one piece of it in a novel setting. So most of us can sort of inhibit certain behaviors when we're in an unfamiliar or sort of a work setting or school setting. But when you're home and you're, quote, relaxed, your motivation, your ability to inhibit, particularly at the end of a day too, when you're more tired, fatigue is a big issue, is compromised. But there may be another factor. There's probably many other factors actually that are coming to play, and some of it is, as I alluded to before, could be family accommodation, and that means that some of these symptoms, whether it's obsessive compulsive symptoms or outbursts, may be actually accommodated, and that reinforces them inadvertently. So these are some of the possibilities for why these are more common at home.
All right, and a follow-up question, recommendations for how a rage can be controlled in a school environment.
Okay, again, excellent question. So the first, I think, the first step in that type of situation is you really have to get a good understanding of why that rage is occurring. And so this comes back to very careful analysis of the symptom, when it occurs, where it occurs, who is there, who is not there, what time of day, what relationship, if any, to food to sleep to medication. What are the co-occurring, or are there undiagnosed psychiatric co-occurring conditions? Is there bullying? Is there collusion with the teacher in bullying a child? I mean, often that is actually going on as well. So is that child have a learning disability, or frustrated because they're really put in a situation that maybe they have an auditory processing problem, and that too is contributing to frustration in the classroom. So there isn't a pat answer here. You really have to do very careful analysis of all the different sort of medical, psychiatric, educational, psychosocial, we'd say, factors that may be contributing to the behavior you're seeing. And until you have a better understanding of those factors, you know, it's really impossible to make an effective intervention.
Thanks, Kathy. And we just have time for just 2 more questions. We do have some more questions coming in, but for this time right now, if you would like to submit your question at support@tourette.org, you're more than happy to, you know, we can field those on our information referral end. But it's just the last 2 questions. So as a young adult trying to work and be with friends in social settings, what do you suggest if I get angry and can't leave the situation?
Okay, so this is an adult with Tourette who's asking about what do I do when I'm in a work situation or in a social situation, and it's not that easy for me to immediately exit. And so again, we come back to this, well, what do you think is going on, and why are you having trouble with the anger disinhibition to begin with? Is it untreated ADHD? Is it untreated depression? Is it that you're having a medication side effect? Is it that you're feeling ostracized in this or sort of socially rejected in this work environment or social environment? I mean, you have to kind of really know all of these different factors. And if you can treat some of them, then you want to get those treated, right? Now assume, let's say you've done that as best you can, and you've really modified everything, and still you're having difficulty. This comes down to having that toolkit of strategies that you can employ. And so, is there, for example, a way that you can do sort of auto relaxation, where you can kind of almost use a mindfulness technique? And we haven't had time to go through what mindfulness is, but where you would allow yourself to sort of just experience that feeling and let it pass like a wave. Just as we use that strategy actually for a variety of things, whether it's anxiety or an urge to eat chocolate or whatever it may be. So it's not intuitive. It's important to work with somebody. As I said, these skill sets, you're not necessarily born with them. You develop them and you improve them and you sharpen them over time. And so in this situation, I would say that it might be helpful, if you've done all these other things, to meet with somebody and work with them on developing these strategies that you can pull out depending on context. I hope that answered the question.
Thank you, Kathy. And just one more question for tonight. My son has TS and OCD. He does not accept responsibility for his actions and will blame others to justify his actions. Any suggestions of how to explain this to him, and should he be punished for those outbursts?
Boy, that's a complicated question here. So you have a child who, at least at surface value, looks like he's not taking responsibility. I'd like to sort of know a little more about age and things like that, of course, but sounds like, in a general description, this child doesn't want to take responsibility, is blaming others for his behavior, and parent is saying, well, what do I do? Do I give him a pass because he's got Tourette syndrome? First of all, it's been my experience that more often than not always, but more often than not, many children who don't appear to have remorse, in fact, do. And so then, again, it comes back to, well, did they know how to handle that situation better? And if not, how can we help them learn how to handle it better? So if you approach it from the standpoint of this isn't just a willful, nasty little kid who wants to hurt his younger brother and make our whole life miserable, if you sort of approach it from the standpoint of, okay, looks like this didn't work out the way we wanted it to, how can we do better next time? And again, not in the midst of a rage, but during a calm period. That kind of collaborative problem-solving type of technique can be very helpful. But I really feel strongly that these types of parenting interventions are not intuitive. They're really hard. Well, they're hard and they're easy. They're easy once you learn the skills and processes to implement them, but they're not, as I said, intuitive. And you really need coaching and support and guidance. So I think this is the kind of situation where, again, you'd probably want to be working with somebody on strategies to intervene. And in terms of not having any consequence for the behavior, well, I mean, that you could say would inadvertently reinforce it, right? If every time that son had an explosive behavior, he got his way, then then he's learned that's a pretty good way to get what you want. But on the other hand, we know that most of the children with Tourette syndrome and associated disorders respond much, much better to positive reinforcement than they do to punishment. So again, you have to think of the behaviors you want to reinforce. It's almost like toilet training when you catch the child doing what you want and you praise them. When that particular little boy you're describing is actually behaving with his sibling or others or making some attempt to regulate himself, well, that's when you want to really praise him, because that's it's hard and it's good work and that's positive reinforcement. So got to remember that these are children who have, I think, a great tendency to get a lot of negative feedback, and there's a great power in positive reinforcement of the pro-social behaviors that you want to have that child develop.
Thank you, Dr. Martin, and thank you to everyone who submitted their questions. Just a reminder, we do have full-time information referral staff at the Tourette Association who can answer your questions as well by emailing support@tourette.org or by calling 1-888-4-TOURETTE, TOURET. So this is all the time that we have for our webinar this evening. And just thank you again to Dr. Budman. Once you leave the webinar, you'll receive a survey on the presentation, and we'd appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view our recording of today's webinar. Additionally, the webinar will be posted on the Tourette Association YouTube channel for those who were unable to participate today. And we encourage you to reach out to us on social media about this webinar and share other ideas or suggestions that you have. And on behalf of the Tourette Association, thank you so much again for joining us and taking the time to view our presentation today.
Thank you, everybody.
Thank you.